Hello and welcome to lecture number 32. This is our third lecture in this series on depression and antidepressants. This is the fourth lecture in this series. What we'll be talking about today are some what we call SSRI plus drugs, which are selective serotonin reuptake inhibitors along with generally norepinephrine reuptake inhibitors. But we'll also be talking today about non-SSRI antidepressants, and some novel treatments such as using the drug ketamine to treat depression. And so that's a really exciting new avenue for treatments of depression. But as always, please be watching out for yourself and others. If you or someone you know is feeling depressed or suicidal, know that help is available. Please reach out to one of these resources if you or someone you know is suffering from depression. Also, keep in mind, these lectures are for educational purposes. Please consult your physician or pharmacist for any questions about your medications or any drugs that you take. So here we are. Today we're going to talk about some of the reuptake inhibitors, and then we're going to spend some time talking about ketamine in particular and talk a little bit about psychedelic treatment for depression. Ketamine is the one we have really good data for, and so I'm going to spend quite a bit of time talking about that because it has been approved for use by the FDA. And there's some really exciting animal data that I want to talk about in terms of how this drug is working. So we'll spend some time in there as well. And then finally, in the next lecture, will be the last one in the depression area. We'll look at alternatives to drug treatment, including exercise, diet, things like transcranial magnetic stimulation, other alternatives like that. But take a quick look here. We've talked already about the sort of top third of this chart of antidepressants. We're now moving into the norepinephrine and dopamine reuptake inhibitors, the serotonin norepinephrine reuptake inhibitors, some serotonin antagonists and reuptake inhibitors that are called SARIs. And then we'll spend a little time talking about atypical antidepressants as well. And then we're going to move in and talk about ketamine. But let's start with these serotonin norepinephrine reuptake inhibitors, or SNRIs. Then we'll get into the SARIs, as I like to call them, and then the NaSSAs, the noradrenergic specific serotonergic antidepressants. So let's start with these SNRIs. Effexor is one of the most commonly used in this area. It includes a serotonin blockade at lower doses, but at higher doses, it also inhibits the reuptake of dopamine. So at lower doses, serotonin, then norepinephrine. At higher doses, it also inhibits the reuptake of dopamine. Side effects for this drug can include manic states, particularly in individuals who are bipolar, agitated or aggressive behavior, significant sexual side effects, elevations in blood pressure, and there's a higher overdose fatality rate. So this is not necessarily a good drug of first choice. Effexor XR has been FDA approved for generalized anxiety disorder, so it's potentially a drug for that class. An active metabolite of Effexor has been approved for treatment of major depressive disorder. Gets similar responses to Effexor, can improve apparently hot flashes in postmenopausal women. So there are some potential other uses for these drugs. Believe me, if a drug company can find another way to market a drug, they will. So that's a potential use for this drug, is for treating hot flashes in postmenopausal women. Cymbalta is our sort of next SNRI. Mildly effective in treating depression and anxiety, does cause significant reductions of physical symptoms of pain, and is approved for management of neuropathic pain. So this is probably the best use of this drug, is for treating idiopathic or peripheral neuropathy. And so that kind of peripheral neuropathy that doesn't have a physical cause, but is caused by that alteration in the response of pain receptors, this is a good drug of choice for that particular disorder. It can induce manic or hypomanic episodes in patients with bipolar disorder, so probably shouldn't be used in that particular population. We'll be talking about bipolar disorder and drugs to treat bipolar disorder in later lectures. Fetzima is comparable in efficacy to other antidepressants. Typical side effects include sexual dysfunction, tachycardia, palpitations, hypertension, and vomiting, which nobody wants. Unlike other drugs in this class, the dose has to be adjusted for individuals who may have some sort of renal impairment. So anyone with kidney difficulties, this is going to have to be carefully monitored in those individuals, or if they're taking drugs that might cause renal impairment, probably need to be also advised to limit use of drugs like Advil or ibuprofen, because those also have significant renal clearance. Sarazone is the first of the SARIs, or serotonin 2 antagonists, reuptake inhibitors. These have a dual action antidepressant. These are related to trazodone, which we talked about a couple lectures ago under tricyclics. Its strongest pharmacological action is at the 5-HT2 receptor. Blockades that particular receptor, inhibits both serotonin and norepinephrine reuptake. Unfortunately, at its therapeutic dose, it can cause liver failure, so this is certainly something to be cautious about using, and has actually been removed from the US and Canadian market, but is still available in generic formulations. So watch out for, if anybody has suggested, nefazodone is the generic formulation of this. It certainly is not something I would recommend because of its toxicity. Because there's plenty of other drugs in the sea, so to speak. So this is not a drug I would recommend, and it's been, like I said, removed from the U.S. market under its brand name. The noradrenergic specific serotonergic antidepressants, or NaSSAs, include Remeron, which blocks the centra-alpha-2 adrenergic autoreceptors. So this causes an increase in the release of norepinephrine, because by blocking those autoreceptors, it doesn't shut off the release of norepinephrine from the presynaptic neuron. Also increases release of serotonin that stimulate only the 5-HT1 receptors, because the 5-HT2 and 3 receptors are specifically blocked by this antidepressant. It's absorbed rapidly, has a half-life of about 20 to 40 hours, does not generally produce the same side effects as SSRIs, but can cause sedation, and also appetite increase and weight gain, along with constipation, dry mouth, and other changes in metabolic factors. So this might be difficult for some people, particularly the increase in weight is probably a pretty significant side effect for most people. All right, well, those are these sort of other reuptake inhibitors. The bulk of this particular lecture is going to be spent on talking about this new frontier, it's this exciting new frontier in which we are using a drug called ketamine, which is essentially a veterinary tranquilizer, which has been abused in the past, and will probably still abused as well. And we've talked about in previous lectures under psychedelics, but this is some exciting new frontier. So let's first talk about what's available for treatment. So in March of this year, of 2019, the FDA approved a nasal spray version called Spravato. This is Esketamine, so it's one of the enantiomers of the racemic mix of ketamine. This is a non-competitive antagonist of the NMDA glutamate receptor. So it's an NMDA glutamate antagonist. So this is completely outside what we generally think of as an antidepressant. And that's what's really interesting about this, is we've now gone completely away from serotonin reuptake inhibition and into a whole different realm of depression treatment. And that's really exciting. And so that's why I want to spend some time talking about it. So how is this drug administered? So this is completely different from, here's your prescription, take these every day before bed. This is only administered under medical supervision, and at this point, only in certain trial locations. So if this is something that you're interested in, you'll have to find a trial location near you in order for you to be able to get this drug administered. It's only under medical supervision. This is a nasal spray. Each nasal spray device delivers 28 milligrams. You get 14 milligrams per spray. The starting dose is 56 milligrams, so 2 devices are delivered 5 minutes apart. So it's a spray in each nostril, and then 5 minutes later, a spray in each nostril. This is given twice a week for 4 weeks, then once a week for 4 weeks. So this is a significant time commitment because you're going to be under medical supervision for quite a while during these time periods. And that's because of the nature of this drug. It is an anesthetic drug. It's also a dissociative anesthetic, so it can have some pretty significant effects. So that's how the drug's administered. Here's from the Spravato website. In that induction phase, twice per week, starting at 56 milligrams and either staying at 56 milligrams or going up to 84 milligrams. And then for weeks 5 through 8, it's administered once a week. And then for weeks 9 after, every 2 weeks or once weekly, depending on the individual and their remission or response. And so this is pretty significant time commitment, but it has really done some pretty remarkable things for people. So, patient is monitored for 2 hours before being allowed to be dismissed, and it's always taken in conjunction with an oral antidepressant medication. So this is for someone who is already taking an oral antidepressant. This is an added drug to that particular regimen. So in terms of the side effects, increases in blood pressure are one of the significant effects that should be monitored during treatment. Significant sedation for up to 4 hours. So generally, you won't be able to drive yourself home from these appointments, so you need somebody to take you and bring you home. Can include dissociative perceptual changes, including distortions of time, space, derealization, and depersonalization, and this occurs in about 60 to 75% of patients. Your cognitive abilities can be impaired for up to 2 hours, and your driving ability for up to 8 hours. So you won't be able to drive for some time after this treatment. So something, again, to keep in mind. This is a significant drug experience, I should say. This is essentially like being sedated at the dentist or for a surgical procedure. It's a fairly similar type of drug. So this is going to be some impairment for some time afterwards. Certainly has significant abuse potential, which is why it's being so closely regulated by the FDA, and only certain centers are allowed to do this at this point. So let's talk about its pharmacokinetics and its efficacy. It reaches its peak concentration in about 40 minutes. Many patients show improvement within 24 hours, and that's really the remarkable part of this drug, is that within 24 hours, people with severe depression are already feeling better, and that is completely different than what we see in most antidepressants. The metabolic half-life is 4 to 7 hours, so it's relatively quickly cleared. Within 20 hours, the drug's out of your system. And so this isn't going to stick with you. You're not going to be loopy and weird for days on end. It's going to be the time after you've had this drug for another 4 to 6 hours or so. So it's a great summary I found from Yale Medicine. In one study, 70% of patients with treatment-resistant depression improved compared to just half who did not receive. So it's a pretty significant improvement. More importantly, more than half of participants show a significant decrease in depression symptoms after just 24 hours. And these are patients who had no meaningful improvement on other antidepressant medications. So this is generally only tried in people who have really not gotten anything out of their antidepressant. And this particular drug has improved a significant number of them, and about half of them within 24 hours. And so this is a really exciting development. So how does this work? Well, there's this really terrific paper that came out in Science by Moda-Sava et al. On the sustained rescue of prefrontal circuit dysfunction by antidepressant-induced spine formation. And so we're going to spend a little time talking about this research, a deeper dive than I normally do in this kind of lecture, but it's so exciting, and this is such a great research study that it's worth diving into. So the first thing they did is they induced chronic stress in mice via cortisol infusion. And so they essentially give the mice cortisol, which causes the same effect as chronic stress. This results in targeted, branch-specific elimination of dendritic spines and correlated ensemble activity in prefrontal cortical neurons and depression-related behaviors. So if you look here at the bottom, we have chronic stress, which resulted in an increase in dendritic spine loss, decreases in ensemble activity of neurons, and increases in depression-related behavior. And so that's the first part of this. So you can see we have baseline. Then we have that chronic stress, and what you can see is reduction in dendritic spines. Then, 24 hours after giving ketamine, they saw an increase in dendritic spine formation and a reduction in depression behaviors. And while, of course, this is mice, this is the way we can see these kinds of activities in these particular mice. What's really exciting about this particular study is the way in which this was accomplished. So what they were able to do is they have mice which had a prism installed so that they could use a laser to scan individual neurons in these particular mice. And so they were actually able to, in living mice, without having to sacrifice them and then do stains and whatnot, they were actually able to use a laser to scan these neurons while they're actually functioning and see how this drug had this behavior, how this drug had this effect. So this is a really, really clever study where they showed the cortisol reduced spine density and the ketamine actually improved spine density. So the antidepressant dose selectively rescued both the eliminated spines and restored coordinated activity and multicellular ensembles. And again, they're able to do this by scanning the brains of these mice while they're alive and intact, which is a whole new change in the way this is generally done. What's interesting is they found that the depression behaviors actually resolved prior to that spine formation, but those spines were actually important for holding on to that antidepressant effect. So if you look here at the bottom, we have injection of ketamine versus just vehicle. So it's basically just saline. And you can see dramatic increase in spine formation as the result of that ketamine use and improvements in depression behaviors. That is, the mice were less immobile, they were up around and moving pretty quickly afterwards. So doing really well as a result of this. So what they saw were some individual differences in the restoration of lost spines, and these were correlated with behavior 2 to 7 days after treatment, suggesting that spinogenesis, that creation of these new dendritic spines, may be important for the long-term maintenance of these effects. So what they're showing is that this single dose of ketamine restored coordinated activity in cells, restored the cells themselves, and actually improved neuronal functioning. And in a previous lecture, I talked about how depression is now thought of as a neurodegenerative disorder. And what we see in humans is reductions in hippocampal volume and reductions in prefrontal cortex volume. And what we are seeing with this drug in this particular study with mice is the single dose of ketamine is improving that neurodegeneration and actually fixing that neurodegeneration very quickly. So this is a really exciting study. What's really interesting about this study as well is they actually included what are called optogenetic mice. And optogenetic mice have a gene inserted into them that is associated with phospholuminescence. I think it's from an algae. And what that gene allows them to do is to turn those neurons on and off, essentially, because of that phosphorescent gene. There's some really interesting videos on this. There's a great video called Memory Hackers where they show how these optogenetic mice are used in other studies. But what they showed in this particular study is when they shut off or deleted those newly formed spines, the antidepressant effects were disrupted. So what they're able to prove with this study is it is these new spines, these new dendritic spines on neurons that are causing these antidepressant effects, because by turning them off, they lost their antidepressant effects. And so that's the critical part of the maintenance of the antidepressant effects of ketamine in this particular animal model. And so this maintenance of antidepressant effects relies on this circuit function, restoration of neuronal functioning in these particular neurons. And this is a really exciting way to think about it. So here's where we are. The acute effects of ketamine are still a bit of a mystery, but the long-term effects are due to its ability to repair neuronal damage from stress. And so that's what's very exciting, is we're able to actually fix what's been broken by stress. And that's a whole different way of thinking about how to treat depression. And that's really where we're at, because this is an exciting way to fix that degeneration caused by excesses of cortisol from high stress situations. So that's ketamine. It's an exciting new part of antidepressant treatment. There are some basic neuroscience research supporting the idea that other psychedelics might be useful in treating depression, in particular psilocybin, but it's really scant data right now. Very limited in humans, and a lot of this research is sort of based in neo-Freudian therapeutic techniques that are scientifically questionable. And so we're not at the point where we can say that these are going to be useful, but we can't say they're not either. And there certainly is some cellular data that supports this particular idea, but that one's a wait and see. And so we'll see how that comes out later on. So once again, if you need more information about these issues, please visit these websites. The article I just talked about on the optogenetic mice and treatment with ketamine is available from Science, if you go to Science Magazine, or the American Association for the Advancement of Science. And I highly recommend it. It's a really terrific paper. And our next lecture, we'll look at some alternatives to drug treatment for treating